Everyone, welcome. Thank you for joining today's Knockout Opioid Abuse Day Learning Series webinar, Trauma and Opioid Use Disorder. Today's webinar is designated for 1 AMA PRA Category 1 credit, 1 ANCC contact hour, 1 ACPE contact hour, 1 AAPA Category 1 CME credit, and 1 ADA CERP continuing education credit by the American Academy of CME, Inc. For any pharmacists who are claiming credit today, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has been approved by New Jersey OEMS for 1 EMT elective CEU. Some housekeeping. PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson, and all other faculty and planners have nothing to disclose. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME, Inc., and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their continued partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to welcome today's expert speakers. I think we're going to have a really important conversation about trauma. And with us, we have Dr. Rebecca Bryan, who is the Executive Director of the New Jersey Department of Children and Families Office of Resilience, Kathy Choi, who is the Program Coordinator of the Trauma Recovery Center at University Hospital in Newark, New Jersey, and Helen DeSalva, who is the Mental Health Counselor with the Trauma Recovery Center at University Hospital in Newark, New Jersey as well. And I look forward to this conversation, and now we'll kick off with Rebecca, with Kathy and Helen, who will start us off. Welcome.
Good morning, everyone. Thank you so much for providing us with this opportunity to be here to discuss this important topic, which is really very dear to my heart. I'm going to begin by just taking a deep dive into the concept of trauma, and Kathy will continue with an emphasis on trauma and informed care. The topic of trauma is so broad and extensive, and so we have a lot to cover, but given the time limitation, I'll do my best to just talk through the main points in this PowerPoint. So moving to slide 3, I would like to begin by just defining trauma, since there's a lot of definitions out there, but SAMHSA defines trauma as the result of an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Well, that was a mouthful, so we will unpack that in the next few slides. If we can just move on to 4. 70% of adults in the US have experienced at least one type of traumatic event in their lives. That's nearly 225 million people. So this is a lot of people, and 90% of clients in public behavioral health care have experienced trauma. Next slide. So many people experience trauma, but don't call it trauma, right? We hear the word being thrown out so often, but trauma can come from many places or experiences. It can happen to anyone at any time, and it can be highly subjective. What may be traumatic to one person might not have the same impact on another. But trauma is often minimized by individuals themselves and by those around them. And it's often minimized in the healthcare field, where it's actually populated by trauma survivors, in both those who provide and receive care. So trauma is everywhere. Next slide. And so in order for us to better understand the profound impact of trauma events on individuals, we're going to take a look at this trauma framework, which looks at a holistic approach to the complexities and the multidimensional nature of its effect. This is known as the 3 E's, as seen in this figure. And the goal is just to hopefully bring to the forefront how trauma may impact the population and the people that crosses your path and improving the work that you do with those individuals. So let's take a look at the 3 E's. We can move on to the next slide. Okay, so the first E represents the traumatic event itself. It's important to note that events and circumstances may include an actual or perceived threat that elicits physical or psychological harm, right? And traumatic events can vary widely in their nature and intensity, and they all share the potential to disrupt an individual's sense of safety and well-being. And I think that's like the key right there. But often when we think of trauma, we think of a single event that causes great harm or pain. However, there's different types of trauma that occur throughout our lives and can be classified as acute, chronic, or complex. Acute trauma occurs as a result to a single highly stressful event, is what we hear often in news, like bad car accidents, natural disasters, witnessing violence. So it can be through witnessing a traumatic event happening to someone else as well. Chronic trauma can be the result of prolonged exposure to highly stressful events. Common examples include bullying, domestic violence, chronic illness, neglect, homelessness, war, right? And in complex trauma results from exposure to multiple traumatic events experienced over a long period, like even months or years. Within this category falls abandonment trauma, for example, which is common among those who experience abuse or neglect during childhood and can cause really long-term problems in physical and mental health. Moving on to the next slide. The second E refers to the individual's subjective experience of traumatic event. So again, people's experience of these events or circumstances, like how they internalize emotional and cognitive responses that happen during and after the trauma, helps to determine whether it's a traumatic event for them. A particular event may be experienced as traumatic for one individual and not for another. So for example, when children are removed from an abusive house, they may describe the situation differently and may respond differently, even though they're siblings later on in life. Next slide, please. Okay, so the third E denotes the effects of trauma on an individual's functioning and well-being. And we know that through advances in neuroscience, we now have a greater understanding of how neurobiology and environmental factors affect trauma, right? It's no longer nature versus nurture. We know it's both. And the long-lasting effects of the event are a critical component of trauma that may occur immediately or may have a delayed onset. The duration of the effects can be short or long term, and in some situations, the individuals may not even recognize the connection between the traumatic events and the effects, and present differently depending on the individual. I mean, in practice that I see daily, I work with trauma survivors, and the presentation varies widely and greatly between the individuals, even in how they respond and what their symptoms present with like. And so we know that resilient factors play a great role on the impact, such as previous life experiences, social support, personal coping skills, early relational health, and community reactions. Again, these factors can influence how an individual responds to a potentially traumatic event. If we can move on to slide 10. So this slide just provides a brief list of its impact, keeping in mind your interactions with the individuals that you come across and how some of these signs seen here may be the result of an underlying trauma. I know there's a lot here to go over, so I'm not going to go symptom by symptom, but just remembering that it impacts emotional, behavioral, physical, developmental, cognitive, interpersonal. So that can look very different from individual to individual. And you'll have these slides for you to take a look at further. Moving on to slide 11. So I just want to emphasize that most responses are normal and that they affect most survivors and are socially acceptable, psychologically effective, and self-limited, right? Meaning that these initial responses are self-protective and may resolve on its own. It's natural to have a lot of these symptoms after a significant event that happen. And some of these initial reactions can include sleep problems, exhaustion, confusion, sadness, anxiety, amongst many others. And some individuals may actually have a delayed response to trauma, and like persistent fatigue, sleep disorders, nightmares, all associated with the trauma. I see patients who initially appear fine after the trauma incidents with very few symptoms, and then within a few weeks, they begin to feel the impact and actually become worse because, and sometimes they're in shock, or they're just kind of moving along in life, and it's not until maybe days, weeks, months later when it finally hits them, showing that delayed response. And so in more severe cases, some individuals will go on to develop a diagnosis of PTSD, and others will move on after the initial symptoms and be fine. So, in terms of PTSD, 20% of people who experience a traumatic event will develop PTSD. So that's 1 in 13 people at some point in their life, but not everyone who has a trauma will experience PTSD. The next slide just goes over what the clinical presentation of the psychiatric disorder of post-traumatic stress disorder is. I'm not going to go over it in detail just because of the time. So we're going to move on to slide 13. Thank you so much. Okay, so a lot of what we just covered is similar over the lifespan with obvious variations developmentally. And when children have a traumatic experience, they react in both psychological and physiological ways. Again, beyond all the symptoms that we just discussed, we have, kids have different patterns in terms of behavior, academic difficulties, sleep patterns, eating patterns that may come to the forefront. If we can move on to slide 14. And so the adverse childhood experiences, the ACE refers to a specific kind of trauma experience in childhood. I'm not going to go into depth about it because our next presenter will speak further about this. But a study in the 1990s found a significant relationship between the number of ACEs a person experienced and a variety of negative outcomes in childhood. So looking at this pyramid, we see that trauma can just profoundly impact an individual's entire lifespan, affecting cognitive, emotional, physical, and social well-being through developmental disruptions, identity and self-esteem issues, impairing coping and increasing high-risk behaviors, health problems, and chronic conditions, which can lead to, an accumulative effect leading to even early death. So moving on to slide 15. I just wanted to touch bases on, how trauma affects the brain. Again, we're not going to be able to go, this is like a whole training on itself, and there's all, but, just to remember that and to elaborate on the neurobiology, we know that trauma can have a significant and lasting impact on the brain, affecting both its structure and function. And so understanding the effects of trauma is crucial for developing effective treatments and support systems that help individuals recover and rebuild their lives post-trauma. I'm going to jump over to slide 17, just because we talk about the factors that influence trauma. We know that there's protective and risk factors, and we're not going to go too much into this. We just kind of went over how, the protective and risk factors change the course of how trauma responds. Okay, so what is the link between trauma and opioid use disorder, right? We know that opioid use disorder is a public health crisis in the United States. And the next 2 slides just go through some facts and statistics on opioid use disorders. And so I'll leave these with you guys for you to review on your own. And we can go on to slide 19. We know that opioids are a class of drugs that interfere with the natural reward pathways, circuitry, and chemical makeup of the brain. And when you use an opiate drug, it binds to opiate receptors to block sensations of pain, and this produces that euphoric rush or high. So this experience can provide a temporary escape from mental and physical pain or difficult memories. And so in those who have experienced trauma, there's often a desire to avoid these painful feelings, and this can lead to opiate misuse. Opiate use can become a way of coping and self-medicating to unresolved trauma symptoms and other underlying mental health conditions. However, trauma can also be the outcome of substance use. And so we know that opiates are highly addictive and can lead to dependence with repeated use. And this can cause difficult emotional and physical withdrawal symptoms, including depression and anxiety when they wear off. And so opiate use can exacerbate mental health symptoms and conditions and can complicate treatment for trauma and ultimately making things even harder in the long run. Next slide. Although experiencing trauma doesn't mean a person will develop an addiction, research suggests that there's a significant undeniable link between trauma and substance use, right? So there is so much statistics on this, and I've tried to put a lot of the main ones on these slides, and I won't go through all of them, but if we can move on to the next one. So studies have shown that more than 80% of people with an OUD have a history of trauma, and those who use opiates have tripled the rates of also having PTSD compared to the general population. And those people who are treated for PTSD and substance use have more severe clinical profile than those with just one of these disorders. If we can move on to the next slide. So the chances of having severe PTSD symptoms were almost 4 times higher for persons with prescription opiate and sedative use problems, followed by prescription opiate and cocaine use problems. And so while examining the co-occurrence of prescription opiate use problems and PTSD, females also had higher prevalence rates than males. Again, another just statistic to emphasize that the most common reported drug in case of the non-medical use category of ED visits were opiates, which was present in 50% of non-medical use ED visits. Here in Newark, we see a lot of this. We can attest to how frequent and how often we are seeing patients who are coming in with overdoses and opioid use disorders. From a medical standpoint, the similarity of symptoms between PTSD and opiate dependence is so high that sometimes it's a challenge to differentiate between these two conditions. So opiate withdrawal symptoms mimic hypervigilance, which results in an exaggeration of the response of patients with PTSD. And so this comorbidity is associated with worse health outcomes, and it's common in the neurobiological circuit. So it can be very tricky when you're seeing patients in the ED that are coming in for both. Next slide, please. And so PTSD and trauma histories can be so deeply intertwined with drug use and addiction that it's so imperative that a comprehensive treatment program, that patients are getting a comprehensive treatment program that addresses all of a person's medical and mental health conditions, integrated in a fashion that is integrated for the best course of action. So it's important that those who are coming in that you are seeing to be screened for treatment of opiate dependence along with PTSD and trauma, and be able to treat those concurrently, and to develop a treatment plan that will appropriately address both disorders. And so now, Kathy will move forward with what trauma-informed care would look like. Thank you so much.
Good morning, everyone. So now that Helen had touched a lot on what trauma is and the effects on trauma on children and adults, I'm going to kind of shift gear and talk about what trauma-informed care is, especially when working with the opioid use disorder population. I think it's important to highlight that when we look at opioid use disorder through a trauma-informed perspective, it's essential to acknowledge the significant overlap between experiences of an individual's trauma and the development of their substance use disorder. Trauma-informed services are very distinct. They're geared towards trauma-specific interventions, designed to address the healing from their traumatic life experiences. But trauma-informed care is not a standard program. It's a set of principles, approaches that can shape the way that people interact within an organization, with clients and patients, customers, and other stakeholders within that environment as well. Subsequently, trauma-informed care is not a one-size-fits-all, and it's an approach to service delivery. Trauma-informed care practices will look different in every organization, and it's really based on the types of services offered and resources available, which can vary from county to county. And by really acknowledging this intersection, we gain a deeper insight into the challenges these individuals face in overcoming the opioid addiction. Can we go to slide 26, please? So according to SAMHSA, the National Center for Trauma-Informed Care, there are 4 assumptions a program or an organization or a system that is trauma-informed follows. Those 4 assumptions are realizing, recognizing, responding, and lastly, resisting to re-traumatization. And additionally, there are 6 key principles that trauma-informed care is grounded upon, which is a strength-based approach, minimizing re-traumatization, and connecting patients with trauma-sensitive supports and resources. And those principles are safety, trustworthy and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and lastly, cultural, historical, and gender issues, which I'll kind of go through during this presentation. Slide 28, please. So the first R is to realize the widespread of impact and understanding the paths of recovery. People's experiences and behaviors are understood in the context of their coping strategies, right? Designed to survive the adversity that's overwhelming circumstances, whether these occurred in the past, they're currently manifesting, or whether they're just related to an emotional distress resulting from hearing from firsthand experiences of others known as secondary or vicarious trauma. There's an understanding that trauma plays a role in mental and substance use disorders, and it really should be systematically addressed in prevention, treatment, and recovery centers. Can we go to slide 29? The second one is to recognize the signs and symptoms of trauma in patients and staff and other systems that are involved. While there are a number of screening tools that we can dive into to really help us identify those risks of opioid misuse or addiction, none of them really have been shown to predict who might be inappropriate candidate for those prescription opioids, for opioids. They also do not replace an open and non-judgmental discussion of issues such as mental health, substance use, or child abuse, gender-based violence, and other experiences of their trauma. I'm gonna shift gear to slide 30. I just want to kind of bring light to viewing symptoms as adaptations. The framework of trauma-informed care, it's very crucial that we have this concept of folks that are their adaptations are often their survival mechanisms. They're developed because it's a response to their past trauma and their adversity. So it's by recognizing such, we can approach patient care with empathy, with understanding, and a focus on healing and their resilience. So instead of having the mindset of what's wrong with you, let's consider what's happened to you. The shift in this language acknowledges that each individual has a unique story and experience that has shaped them in their current situation. We also want to understand the patient's symptoms. So every symptom exhibited by clients can be a survival mechanism rather than simply looking at it as a manifestation of their pathology. And so by reframing symptoms in this way, we can better understand and validate the experiences of those individuals seeking support. Slide 30, please, 31. The third is to respond by integrating knowledge and trauma into our own policies, procedures, and practices within our facility. Organization-wide awareness of applying trauma-informed care is so vital to recognizing traumatic events impact everybody involved, directly or indirectly, from the front line, the reception, to the security guards, to the clinicians, to the executive board, to the governance board. Languages, behaviors, policies, they're all adapted to consider the experiences of trauma among both the clients and the staff. Leadership also ensures that staff work in an environment characterized by trust, transparency, fairness, and that some investments in training and support where they prioritize on ongoing trauma and leadership support. Slide 32, please. Lastly, the last R is to resist traumatization, and staff are trained to recognize how organizational practices may inadvertently trigger painful memories and re-traumatize clients with their trauma histories. And by understanding the potential impact of their actions and organization practices, staff can assure that interactions are sensitive, supportive, and conducive to healing. I just want to shift gears to slide 34, which are the core principles of trauma-informed care in various settings. The first one is safety, which is a core foundation for any human beings. So patients feeling safe in the care of their healthcare professionals. Safety generally means maximizing control over their own lives for patients, where on the other hand, providers' safety typically involves maximizing control over their service environments and minimizing risk. Slide 37, please. The second principle is trustworthiness and transparency. Just kind of highlighting every interaction matters, with a warm smile at the security desk, to navigating conflict conversations in a safe and respectful ways during treatment. And many individuals hesitate to seek medical treatments due to lack of trust. And so we just want to ensure understanding of options, being authentic in our interactions, and addressing limits to confidentiality. 38, please, slide 38. The third key principle is peer support, and and mutual self-help are key factors for establishing safety, hope, building trust, enhancing collaboration, and utilizing their stories and lived experiences to promote recovery and healing. Slide 40. The fourth key principle is in trauma-informed care is collaboration and mutuality, where experience of trauma often leaves individuals feeling powerless with little choice or control over what's happened to them. So it's so important for everybody involved that sharing expertise and power between the providers and the patients, where the patient has a say in their treatment goals and their plan of care throughout their treatment. Slide 41. The fifth principle is empowerment, voice, and choice, where individuals' strength and experience are acknowledged and leveraged by fostering a sense of empowerment, voice, choice in their healing journey. And the organization cultivates a belief in resiliency, supporting clients in developing that self-advocacy skills and self-empowerment skills. The last one is cultural, historical, and gender issues. So clinicians really need to recognize and eliminate any potential cultural, racial, gender, or other biases. We want to encourage practitioners to stay up to date in the latest research regarding sex-specific effects of opioids, their treatments, and knowledge into their clinical decision-making process to improve access and satisfaction within the service provisions we provide. Just the key takeaway on slide 44, it's really about the fact that trauma-informed care is not a one-size-fits-all approach to service delivery, starting with our strength, creating promoting strength, their victories, and celebrating with our participants, working and creating that physical, emotional, and cultural safety for everybody, including staff, and making necessary accommodations.
Thanks so much, Kathy. And Helen, I know you both had so much information to share with us. And as we're, trying to fit that into today's webinar, I appreciate the information that you shared. It was really significant and important. And just want to make note for that information that you weren't able to touch on, but that you had included in your slides. The slides will be made available to all attendees, so you can go ahead and review those. We're going to hold question and answer until after our next presenter. And Rebecca Bryan, I'm going to turn the presentation over to you now.
That's great. Thank you so much for this opportunity. So I am from the Office of Resilience. We are a proud team of 7 trying to help to shift our wonderful state to become a trauma-informed and healing-centered state. And I love this quote: our lived experiences, both good and bad, become our biology. And I want to thank Helen and Kathy for their presentation. And the key takeaway points are a wonderful setup for what I'm going to share with you today. So next slide. So I wanted to give updates. I know that most of you are aware of the adverse childhood experiences science to some degree. So trying to show how the science is evolving. The infographic on the right-hand side here shows actually 4 levels of adverse childhood experiences. So in the roots of in the branches of the tree, you have the original 10 categories that were very much about relational health. Above it, in the sky, you see the adverse climate experiences, and note that COVID-19 is absolutely an ACE. In the roots of the tree, you see the adverse community experiences. So you can have children who are growing up in very stable, loving, safe, nurturing relationships, but it may be that their community is putting them at risk for adversity. And finally, down in the soil are the atrocious cultural experiences, including, of course, the history of our country, with, particularly, I think about structural racism and systemic poverty that spans generations, right? And we know that adverse childhood experiences impact on our health and well-being includes genetic expression. And it has been demonstrated that if ACEs are not resolved, named, and transformed, they are transmitted through the generations genetically, I think also behaviorally. So important point to make to that. And on the left-hand side, I have my favorite definition of trauma, because it shows that it is doesn't only happen in childhood, although in childhood is particularly impactful, but this idea that trauma is not what happens to you, but what happened inside of you as a result of what happened to you. It is experiential, and it really speaks to what Helen and Kathy were saying, which is it is a subjective experience, and it is up to the individual to determine what that is. Over half of the adult population, 62%, has had 1 ACE, and a quarter, 25%, have an ACE score of 3 or more. Most reported childhood adversity in those with current opioid use disorder was emotional abuse. ACEs have the potential to generate toxic levels of stress, which tends to be pervasive and chronic. It gets underneath our skin, overwhelming our coping mechanisms and shifting our stress response from adaptive to maladaptive. But note that I say it has the potential to do that, right? It's really up to the individual to define it. And the research I'm going to share next is showing that there are mitigating factors in children's and adults' lives that can really make a difference on how an experience is experienced. But a metaphor that's helped me understand of the continuum from what's called little t trauma to big T trauma is the idea that all trauma wounds, it hurts, but not everyone who experiences trauma is going to develop PTSD. PTSD is like an infection in the wound. And so it is true that people who are ACEs impacted, they had significant ACEs in their childhoods, are at increased risk of developing PTSD, but that's not a given. Next slide. So this is the research that I love. Since 2019, really, I'll say now that I've done more research is since 2013, this construct of positive childhood experiences is being discussed. And there, the infographic I have here is available on our Office of Resilience website, and it is reflecting the research by Dr. Christina Bethel out of Johns Hopkins University. She has studied 7 positive childhood experiences that are embodied. It is up to the individual to say that they have felt these things, not up to somebody like me, a clinician, saying, oh, you must have these positive childhood experiences because you have this, in your life, right? So to me, that's the way I differentiate between protective factors, which is something that we can look at from the outside and observe, versus positive childhood experiences, which are embodied and the individual names them. But you see here, it has to do with relational health, right? So PCEs, that I'm going to refer to positive childhood experiences as PCEs, the association between PCEs and opioid use disorder, the results are mixed right now. However, what is known is that positive childhood experiences promote resilience. And resilience mediates the association between adults with ACEs and adult prescription opioid misuse. Another important takeaway point with positive childhood experiences is that they coexist with ACEs. So it's not that kids are either having an adverse childhood experience at one end and a positive childhood experience at the other end. It's not like that. They happen simultaneously. And what's really neat to see is that when kids have high levels, or adults looking back at their childhoods have high levels of positive childhood experiences, which on this scale would be a 6 or 7 out of 7, it has an undoing effect on the risk conferred by ACEs for chronic physical and mental health. And it increases the likelihood of having healthy relationships in adulthood, which are additionally protective. In fact, PCEs may actually be more impactful on health and well-being than ACEs are. Next slide. So pulling this all together, again, our lived experiences become our biology. They impact our brain development, our genetic expression, and our immune system and hormonal system development, as well as behaviors, our worldview, our attachment style, you can go on and on. Within our lived experiences, we have coexisting these adverse childhood experiences and these positive childhood experiences. And you see in this infographic from the CDC that when you have an ACE score of 4 or more of the traditional 10, it increases your risk for all these different points that are shooting out here from the circle of adverse childhood experiences. 2 recent systematic reviews demonstrate significant associations between ACE scores and opioid-related behaviors, and between all individual ACEs and lifetime opioid misuse, such that for each unit increase in ACEs, so each time the ACE score goes up by 1, the odds of opioid misuse is increased by 4%. And the odds for misuse of non-medical prescription opioids, which I'll refer to as NMPOs, were 3.5 times higher than those with 1 or 2 ACEs compared to 0 ACEs. So it doesn't have to be an ACE score of 4, 5, 6, 7, right? Even having an ACE score of 2 can increase your risk. And the odds are increased to 7 times higher among those with 3 or more ACEs. Women with ACEs are more likely than their male counterparts to be diagnosed with OUD, and they had higher mean ACE scores than men. Women also had significantly different experiences that increased the likelihood of OUD, specifically childhood sexual abuse compared to men. People with a history of sexual abuse have greater odds of NMPO use, and the odds of risk for lifetime NMPO use was almost 5 times greater than among those with no history of childhood sexual abuse, while those who experienced both sexual and physical abuse reported even higher rates of opioid usage, upwards of 27%. Parental substance use increased the risk of opioid substance use by 50 to 60%, as did parental separation. Those were the most reported types of ACEs associated with opioid misuse behaviors. Next slide. ACEs among people who with current OUD, you can see here. So even though we know that emotional abuse and sexual abuse definitely plays a very large role, all specific types of ACEs were significantly associated with OUD. People who experience ACEs have a greater odds of recent injection heroin use. I thought this was really telling. Adolescents with greater than 5 ACEs had a much higher odds of recent opioid misuse than those with 0 ACEs, calling for interventions at as early an age as possible. The cumulative increase of childhood adversities was associated with a lifetime overdose use. So we know that these stats are cumulative. And greater ACEs were significantly associated with initiation of opioid misuse, again, at a younger age. So calling out for promoting those positive childhood experiences and creating environments where parents and adults in their lives can create safe and stable nurturing relationships with children. Next slide. So why does this association exist between ACEs and OUD? It can be because of the stress response. As I said, the toxic stress shifts adaptive responsive to maladaptive. It can be because of relief of emotional pain, right? We know that the way our brains are wired, the same pathways that transmit physical pain transmit emotional pain. I'm actually listening to a book right now by Donna Hicks about dignity, and the fact that an injury to our dignity, right, our self-worth, can feel like a gunshot wound to the heart. And who would not want some relief from that? Neurobiological impact of adverse experiences, both ACEs and OUD make lasting alterations in our brain structure as well as our biochemical pathways. And then disruption of the immune system can result in painful autoimmune conditions. Next slide. So how do we respond? Well, it turns out that asking, listening, and accepting are a powerful form of doing that appears to provide great relief to patients. This is a quote from one of the original ACE researchers, Dr. Vincent Felitti. And I love this quote because a lot of times the hesitancy to talk about adverse childhood experiences by clinicians is on the side of the clinicians. The clinicians don't feel comfortable talking about it because they don't feel like they know what to do about it. But actually just affirming someone in their lived experience is hugely helpful in and of itself. And we need to create communities that know how to do that. Next slide. So I'm echoing again what the former presenter said. We are called to make this paradigm shift. Instead of asking what's wrong with you, you ask what happened to you, because when you understand the trauma, you understand the behavior. And then I'm inviting you to make the next shift into the work of Sean Ginwright, which is the Flourish Agenda and the healing-centered engagement. And that's asking what's good with you, right? What gets you through it? Because the human spirit is incredibly resilient, and we are not the sum of our trauma. Next slide. This is a table that, again, you're going to receive these slides, and so you can sit with this all you want. But what I really appreciate about this is traditional medicine, and my background is as a nurse practitioner. Traditional medicine is considered the allopathic model, and that is as clinician as the outside observer, which is an etic approach. And that really goes down to asking what's wrong with you. Even if it's a thoughtful what's wrong with you, it's still asking what's wrong, right? Then moving to that trauma-informed approach is an emic approach. It's stepping into the patient's shoes or the client's shoes, and it's understanding them from their perspective. It is putting the client or the patient in the center of the healthcare team and realizing that we need their voice to make decisions or suggest interventions that will actually make a difference. And then moving to healing-centered engagement, which is that people are more than their trauma, and that there is power in naming their strengths first. The idea of cultural identity as a source of resilience, that patients are not treatment targets, but full human beings that deserve to be flooded with opportunities to reach their full potential, and understanding behavior as an indicator of stress or inequity in the community rather than an individual flaw. I always add at the bottom of this, it's not about what happened to you, it's about what it left you with that matters, which is from Tarana Burke, the founder of the Me Too movement. Next slide. We're really looking at helping people to shift rather than remove and replace coping mechanisms, right? So recognizing that substance abuse is more than likely a coping mechanism. We are helping the individual to manage emotional responses that the survival brain has perceived to be deeply threatening. So for me, this infographic, which I love, drawn by this artist, Lindsay Brahman, of whom I am a supporter. This is a great metaphor for the principles of harm reduction, right? We're not trying to remove what worked for them in the past. We're saying, let's acknowledge that that maybe is not the healthiest thing for you, and that maybe we can build these positive coping mechanisms so that eventually we can, we can shrink the negative skills and increase the ones that promote health and well-being. Next slide. Practice implications for wherever you are, whatever the setting is. It is really helpful to identify a history of trauma. Yes, that means screening for it. Screening needs to be done in thoughtful ways by people who are trauma informed. But again, you don't necessarily need to know how to fix it as much as you need to have the skills to be able to affirm and reflect back what you're hearing. Detecting opioid use triggers, offering trauma-informed care, addressing ACEs in people exposed to opioids, seeing the strong connection between the two. SAMHSA has a whole description, which I don't have the time here to discuss, but seeking safety therapy is something to investigate. Prioritizing strengthening resilience in ACEs impacted individuals, and what I bolded here: promote empathy and understanding of the circumstances behind a person's opioid use-related behaviors to reduce stigma. I read an article recently about how the reduced restrictions on prescribing Suboxone has not increased access to Suboxone to the degree that it was hoped. And that's because the providers don't want those people in their clinical settings. And I immediately thought when I read that, man, they need trauma-informed training so that they can make the shift from asking what's wrong with you to ask what happened to you, to ask what got you through it, right? To increase empathy and understanding of the circumstances behind a person's OUD behaviors. Next slide. So this article is listed in my references. I just want to point out what I bolded here. Resiliency may be the key to opioid use prevention, particularly in people who are ACEs impact, and whether they're children or adults. And clinicians may be helped by using risk-based assessments, promoting resiliency, and including families in the treatment, because we have to realize that people don't exist alone. They live in context of others. Next slide. So here's something that I feel like I'm coming full circle on. I used to work at Urban Promise Ministries in Camden and used to promote the 7 C's all the time. But there are many models of resilience when you think, well, how do I promote resilience, right? I did want to highlight work that's being done by our Department of Children and Families. On the left side here, these are the sources of resilience that we're promoting. And on the right side, you have these 7 C's that when they are in place, people tend to be more resilient. What's really great about these is that we have agency in this. We can work on being more confident, competent. We can work on having more connection. We can have conversations about what does it mean to have character, like it is what you do when nobody else is looking, right? You can contribute by volunteering. You can work on shifting your coping mechanisms to healthier. And we can see boundaries, right? Where we have control, where we don't have control, and let go of that which we don't have control. So with that, I think we have time for questions, but I really thank you for this opportunity, and my references are included.
Thanks so much, Rebecca, Helen, and Kathy. All really great information. And we have some questions, and you're right, we have some time to get to those questions. So, Rebecca, I'm going to throw this to you first, just because you shared with us that you used to be a nurse practitioner, or that's where your background is in being a nurse practitioner. We had a question for looking for some recommendations on initiating resources for trauma in a critical care setting. Attendees said currently our facility does not have prompt psych care in a critical care setting. The opioid use is often a result of the trauma that our patients are experiencing. We don't have appropriate resources available currently. What are some recommendations that you can make currently? They're consulting outcomes manager for outpatient resources, but is that enough? And Rebecca, will go to you, and then Kathy and Helen, if you have anything to add.
Yeah, there's no easy answer for that. I think what has helped me the most is, I'm going to go back to that quote I had from Vincent Felitti, which is that it turns out by asking, listening, and accepting, they're a powerful form of doing, which appears to provide great relief to patients. I think what hurts the patients so much is that when they're in a healthcare setting and they're feeling nonverbal communication of shame and stigma or lack of understanding. And I think being treating someone with dignity does more than you think in terms of helping. And I actually see healthcare providers as a therapeutic tool in the room. You yourself, depending on how your tone of voice, your facial expression, what your nonverbal communication is, as well as asking people what they need and listening to their voice, rather than presuming that you know what they need, right? Because that has helped by far the most for me.
Thanks. And Kathy, I'll go to you next. Anything you wanted to add to that?
I think the good thing about our hospital is that they've really invested to the work of trauma and being trauma-informed care. So Trauma Recovery Center here at University Hospital, we provide victim services to folks who are above the age of 12 in counties such as Bergen, Essex, Union, and Hudson. We are free of charge, and all of our clinicians here are phenomenal expertise on trauma care, and they're all specialized in EMDR as well. So if anybody right now on the call needs us, please reach out to us. And the eligibility is that you must have a victimization within the last 5 years, or that you have had a history of child abuse or neglect.
Thanks, Kathy. And Helen, anything you wanted to add to that?
I think, as Dr. Bryan stated, it's a complex topic, and it begins with the first contact with the patient. And I think that sets up what it will look like moving forward. And it is about utilizing the community. So even when you're at a place where you can't have all, in the best case scenario, somebody can come in and you identify that there's trauma and it can be treated in one setting, but that's not always the case. So having community resources and making the appropriate referrals, I think, is already a big step, because we can only work as a community and in a group, right? We can't I truly believe it's really difficult to have one setting to do it all. And so as long as those connections are made, and I think that's what's really, really important.
Absolutely. Thank you. Another question is, we have someone who's writing there, trying to find resources, how to talk to their children, specifically children who are in college, looking for help to deal with the stress. Obviously, there's the stress of everyday college life, as well as all of the current events and things that are happening on college campuses right now. So any advice or tips? And Rebecca, will go to you first.
We're coming out of the pandemic where we were all alone for a couple of years, and particularly the kids who are in college now. I think they were so profoundly impacted. I have young adult children who were profoundly impacted. And I feel like we're relearning to connect. But at the end of the day, it's about relational health. I'm so convinced that relational health is the key to promoting resilience. And so I think it's having conversations on how do you reconnect, and recognize even that your nervous system may not feel comfortable being in a group of people because for a couple of years you weren't. And even now we still hear, of outbreaks and don't even talk about the gun violence that's happening, on campuses. And so it's finding ways to be in connection with others, with people who have the ability to, when we're in a storm, to calm the storm. That the idea of co-regulation, and that's not easy. But again, I'm going to assert that the human spirit is resilient. And I think sometimes I saw somebody in the chat say how the power of psychoeducation, and I think sometimes young people recognizing that we are wired for connection, and that means physical proximity to others, that they have agency in moving towards that and relearning how to be in connection, and add on the whole AI and smartphone phenomena too. And it's just important to name it and to recognize what we're wired for.
Thank you. And Kathy, anything you wanted to add to that?
I think a lot of universities now have help centers or counselors that are embedded within the campus. And to Rebecca's point, I think the social connectivities or activities that are going on is very much encouraged now. Even with therapists, we do hybrid where it's remote and in person that they can benefit from. So I think it's really about the connections and finding the resources that are available.
Thanks. And Helen, anything to add?
Yeah, I think what both of them said is really key. However, as a parent myself of a teenager, I think that conversation starts at home, which it sounds like, from the post, this parent is already having these discussions. And I think that's where it starts, that safe, that connection to your child, which may not always come easy, right? But having conversations of these topics, that it is okay to be that there's change involved in this college life, and that there may be symptoms, and the psychoeducation component, and it's okay to get that extra support, whether from individuals around or professionally, right? I think parents can definitely have that conversation and reinforce it with their children in all ages in different stages.
Absolutely. And I'll add, the Partnership for Drug Free New Jersey does have some resources available just to raise awareness or to help parents have those conversations that don't necessarily have to be about this topic, but just making that relationship is stronger so that children will come to their parents and discuss the stresses that they're feeling and other issues. We'll put that information in the chat about the programs that we have available that are free of charge that you can use in your community as well. Again, we have about a minute left, and I know the survey has popped up and there's information on your screen on how to get credit. But before we close out, I just want to give our expert panelists who did such a wonderful job in sharing so much important information today one last opportunity to just have one last comment with the takeaway point. And Rebecca, I'll go to you.
I think that the research on positive childhood experience is the other half of the puzzle. People have been focusing exclusively on ACEs. It's been such a downer. Very important. We need to acknowledge people's suffering, but recognizing the positive childhood experiences that coexist and how they point to the value of relational health is the takeaway point I want you to hear. Thank you.
Absolutely. And Kathy, I think earlier you mentioned a helpline, or if anyone needed help, they could reach out to you. If you could just throw that in the chat. I saw we had a few questions looking for that information. But before you do that, any last point to leave with our audience?
Yeah, I trauma-informed care is not a one-size-fits-all approach to service delivery. It's not a program, and it's a set of principles and approaches that really shape what we can offer to empower and to provide to the population that we do serve.
All right, thank you. And Helen, our final note of the day.
Yeah, I think just coming, piggybacking on what Kathy said, I think just on trauma in general, because it's thrown out there. So, it's just everywhere, the word, but just, having conversations, being caring, being empathetic, how we approach individuals everywhere. I think it starts there in all our connections, not just in the healthcare setting, but just being curious about why people respond the way they do, because there may be underlying pain that we're not seeing. And so just that initial connection of being kind and curious wherever we go, I think is already a powerful statement that
Wow,
can contribute to that.
such a great note to end on, something we can all do, regardless of where we are in our professions or what our backgrounds are. Again, I thank all of our panelists. It was an excellent presentation today. Really appreciate your time on this. And all of our attendees, thank you so much for being with us. Thank you for continuing this conversation as we explore different issues that impact the opioid crisis that we continue to face in New Jersey. Again, additional information on how to access continuing education credits is on the screen, and additional information is in the chat. And we'll also be providing you a link in the next 24 hours to a recording of this webinar, as well as the slides that our presenters use. Thank you again, everyone. Be well. Have a good day.
Thank you so much. Bye-bye.
Bye.